we are going to start off with the first section of the day, which is extremely sensitive, and I'm pretty sure all of us somewhere deep inside are also scared about the cancers of the reproductive organs. So, relooking the entire reproductive cancers through the functional lens becomes extremely vital. And one of the areas which is usually underlooked, and I would personally also say, is usually the males in the societies, the issues of the males are usually not seen in the way or highlighted in a way to a level that which they should be concerned. And yes, but I do know all of you who are attending over here are definitely looking in for insights, and that is why the first session of the day is related to a very, very vital, sensitive, and sometimes even taboo topic, I would say. It's related to the prostate cancer and the hormone connection with it. So, I would love to introduce you to the first speaker of the day, uh, Dr. Ashok Kadambi. He will be highlighting us with and enriching us with his important insights about this topic. Dr. Kadambi, allow me to introduce you for a minute. So, Dr. Kadambi is the president of the Fort Wayne Endocrinology in Indiana, USA. With over 2 decades of expertise in hormone optimization and chronic disease management, Dr. Kadambi founded his clinic in 1999 and has since made significant contributions to healthcare, including the establishment of a satellite clinic known as Bella Sante in Bangalore, India in 2010. Dr. Kadambi, you're going to be taking a very, very vital topic related to prostate cancer. And with that, I would hand over the stage to you to give this enriching session. Welcome to the conference, Dr. Kadambi.
Yes, thank you, Ms. Amarjeet, right?
Yes.
Thank you, Amarjeet. You're the coach, so that's nice. Uh, yeah, I would. First of all, it's always risky to be the first speaker because you get kind of people straggling in and still having their coffee and their breakfast. Is this a live conference also, or just online?
We are on a live conference and everyone is sending their claps and they have also welcomed you,
Oh,
which I can see. So, yes.
Let me correct it, Ashok. It's only online. There is no live.
oh,
I
only
mean,
on.
it's live. It's
Okay.
live, but what you mean is not a hybrid mode.
Oh, it's not a
But it
hybrid
is
mode. Okay.
live. We can see more claps are coming in.
Yeah, yeah.
So,
Okay,
people
It's
I
are
see.
live.
watching you.
It's
Yes,
I see
live.
yes,
74 participants. Okay, that's good.
yes. And
Yes.
adding on. So, we can start sharing the screen, sir.
Okay, please. Now, do you have my presentation?
Do you want me to do that for you?
Yeah, I can do that. If not, I can do it myself.
Would you like to try?
Yeah, I can try. Hang on.
Sure.
PowerPoint.
I'm moving away from the screen. However, I can see you. You can
Okay,
share the
can you
screen.
see? Okay, now to share the screen, what I need to do is
Share.
share the screen.
Yeah.
Um,
There is a share down green button.
hang on, hang on.
Yeah.
Yeah, share. Okay, share your
Got,
screen sharing.
yes,
That's
we
on,
can see
right?
that. Let's put it on a slideshow mode.
Okay, slideshow mode. PowerPoint, maybe where is the slide share mode?
Just go to the slideshow, that menu button. On top,
Okay.
on top, there's home, insert, draw, design, transitions, animations,
Yeah.
and then there's
Home.
a slideshow. Let's go to the slideshow.
Okay.
Click on the slideshow, please.
Okay. Slideshow. Yeah, there you
Yes.
go.
And play from start. The first option down there. Play from start. Left
Oh,
side,
play
please.
from start. Let's say.
Yes, 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 please. Yes.
Right. Now you see it.
Perfect.
Right?
Perfect.
See, you see me also or just a slideshow?
We see you as well.
Okay. All right. That's fine. So this is the slideshow mode. Okay. Now I got it. So I'm going to minimize that screen there. So let me start off with saying, everybody is heard of hormones, right? And for a lot of reasons, there's a lot of fear associated with it. And one of the myths this is more like a session to dispel any myths about testosterone as it concerns prostate cancer. Um, of course, I cannot poll the audience. I would like to see a show of hands as to how many think testosterone is a dangerous hormone. Probably
People
half the
can put
audience.
in a thumbs up. Let's put in a
Thumbs
thumbs up
up.
for Dr. Kadambi. How many of you feel what Dr. Kadambi has just said?
How many of you feel that testosterone is a dangerous hormone, particularly as it relates to causing cancer? I see a lot of thumbs up. That means good or bad. That means they think it is. Okay, let me present an alternative view. Okay, I wouldn't say alternative. Let me present a more evidence-based view about this because people buy whatever they people just assume whatever is being told to them is true and then just go with the hypothesis, whereas they never question the hypothesis itself. Biologically speaking, testosterone is an anabolic hormone. It is apoptotic, actually causes death of cancer cells. And then how is it that testosterone came to be linked negatively with prostate cancer? So today we're going to talk about the myths and facts. I'm going to keep my presentation quite short, but and that will open up a lot of time for questions. So I don't want this to be a monologue. I would like some feedback from the audience in terms of questions. I want to answer all your questions before you leave. So testosterone and prostate cancer, what are the myths? What are the facts? What's the connection? So we go, okay, now, okay, how do you go to the next slide? Okay, that's it. So let's walk down memory lane a little bit of history here. How did this testosterone come to be? A connection with prostate cancer come to be? Dr. Huggins, a U.S. physician, I believe, actually castrated a prostate cancer patient and demonstrated uh, very eloquently a shrinking of prostate cancer in 1944. One patient, one. Now, look what happens. He then goes on to win the Nobel Prize in 1966 for his paradigm shifting work in prostate cancer as it relates to testosterone, which then found associations in other hormonal cancers such as breast cancer. So we heard of estrogen blockers in breast cancer, right? So this is how it happened. So they somehow felt, the Nobel Committee, that there's a clear relationship between cancer production and hormonal levels. So the pharmaceutical industry started shifting their attention on something called ADT, or androgen deprivation therapy, which of course then by de facto became the standard of care for prostate cancer. So let's examine what this ADT actually is and what are the other options we have. So the question is, testosterone, does it increase cancer risk or not? That was the question. Well, according to conventional wisdom, it does, because you know why? Because taking away the testosterone causes shrinking of the prostate cancer. And that logic is actually not completely true, because just because something caused something doesn't mean that was the reason for it. Okay? In other words, association does not prove causation. So just because you lower the testosterone levels to zero and the prostate cancer shrank, it does not in any way mean that testosterone actually caused the prostate cancer. That's what I mean. How do I know this? Because the most aggressive cancers are associated, believe it or not, with low testosterone levels. So we're talking about like severe cancers, all right, also being associated with low T levels. And high testosterone levels paradoxically are associated with very low risk. Now, there's one more caveat to that. Not only are the most aggressive cancer associated with low testosterone levels, the lower the testosterone level, the more aggressive the cancer in terms of Gleason score, which actually which actually grades the cancer as, less aggressive, moderately aggressive, and more aggressive on a score of 1 to 10. Gleason score of 8 or 9 is very aggressive, 1 or 2 is not so aggressive, 3, 4 is in the middle. So, so that is basically our statement on testosterone and prostate cancer. That observational studies don't quite suggest that testosterone has any role in causing prostate cancer. And in fact, the reverse is true. So, what are our treatment options? Now we have a patient with prostate cancer, your father, uncle, anybody, grandfather. One is to do nothing. And this is also a valid way of treating because most people die with prostate cancer, not because of it. Okay. And most cancers are indolent, they don't really spread. And that tend to, especially those that occur and later on in life, 70s, 80s, 90s. You just watch and do nothing. Just watch the PSA, make sure there are no metastasis. So essentially, observation and monitoring is a very, very good way to treat prostate cancers to do nothing, just surveillance. The other option is to do surgery, and there are so many surgeries now available with the advent of laparoscopic and robotic surgery, even that the prostate cancer surgery can be very well defined, can be limited, can be nerve sparing, can maintain urinary and sexual function indefinitely. So you don't have to give up a lot, and the surgery can be very successful. So that is a very good option for treating prostate cancer. Another option is radiation. Either you can do external beam or you can implant those radiation pellets. So that is basically what we're saying in terms of these three things. And then lastly, after you do all this as an adjunct, you can also, or even as a front line, you can do something called androgen deprivation therapy, ADT. So what this basically means is medical castration. So rather than surgically remove the testicles, what they do is they give you something to reduce the formation of testosterone, okay, by by using FSH, LHL, luteinizing hormone analog such as Lupron depot, which is monthly injection, and something called Calcidex, which blocks the androgen receptor, blocks the effect of testosterone. What little remains on the testosterone receptor. So they call it ADT. So this, of course, has a lot of side effects, and we'll talk about that in a minute. So, what are the side effects of ADT? One is very severe fatigue, okay, something we call brain fog. The brain fog is nothing but confusion, loss of memory. Um, in the extreme case, of course, some form of dementia, maybe leading to Alzheimer's, but definitely confusion, loss of memory. Uh, they're not just as alert as they used to be, causing significant impact on their quality of life. This fatigue, brain fog, muscle wasting weakness, and this is again a big deal because in the elderly, wasting weakness can actually lead to imbalance, especially the fast muscle fibers. They cannot regain control when they fall and they may break their hip. And that, as you know, is a pathway to eventually leading to death in a nursing home. Bone loss, severe osteoporosis causing fractures. Okay, this musculoskeletal side effects of ADT are nothing but the side effects of low testosterone. So if you see an elderly male with these symptoms, definitely look for low testosterone. ADT also tremendously increases cardiovascular risk in terms of atherosclerosis. One of the things to prevent atherosclerosis is to have good, healthy testosterone levels. To the extent that you had in your 20s and 30s, that we see very little cardiovascular problems in that age group. And part of the reason, of course, is because the testosterone levels for males are quite high. It's only when it goes down do they increase your cardiovascular risk. Of course, I didn't quite add this, but metabolic problems like increased risk for metabolic syndrome, increased risk for diabetes, that also plays a big part. as far as the side effects of ADT is concerned. And lastly, of course, the most severe cases you can have quite push you into dementia, especially if you're like a borderline, if you like if you had mild cognitive impairment from say Alzheimer's, and you deprive the brain of testosterone, you then eventually push them into something called dementia. Now, let's look at some biochemistry, some basic modeling here, basic science. There are, as you know, androgen receptors on every cell in the human body, and particularly prostate tissue is very rich with androgen receptors. However, once these receptors get saturated, there is no further effect on PSA. And that level is supposed to be around 200 nanograms per ml. So up to 200 nanograms per ml, no effect. Complete castration, good effect, you lower your PSA. Okay. Now, lowering PSA doesn't mean the disease is under control because, as you know, they eventually, if the tumor is aggressive, they become androgen resistant or androgen independent, and they can obviously metastasize. So, this, I think, again, is more treating of the doctor than treating of the patient that you want a PSA level around some magical number below certain levels. Closer to zero, the better. So with the ADT, you can get your testosterone levels pretty much near zero. Okay, and then of course, then claim that of course you have cured, you have achieved remission of prostate cancer, and to maintain the remission, they must be on ADT lifelong. Again, not a very healthy prospect because you've cured the cancer, but the guy dies of heart disease or gets demented or has uh, severe poor quality of life of what remains. And particularly if they're elderly, again, what have you gained? You know, you've killed the patient, but you've cured the cancer, essentially. At least they didn't die of prostate cancer, they died of a heart attack. That's the justification. Now, there are some alternatives to ADT. ADT, I personally would not recommend to anybody. And I give you why what my reasons are. But having said that, what other things do we have in our arsenal to treat prostate cancer? Well, no ADT, just surgery, radiation therapy, and observation. That's again acceptable. We could add estradiol to mitigate in case you have to, in case ADT is insisted, if if the doctor insists on ADT, you can ask the doctor, what about estradiol? So estradiol can be added to mitigate side effects of ADT. Now, that may seem kind of lopsided because, I mean, it may seem contradictory because, on the one hand, you have a male patient, and the other hand, you're giving them estradiol. Isn't that a female hormone? Actually, both estradiol and testosterone are both male and female hormones. The only female hormone actually is, I would say, is progesterone. But we're not talking about that now. We're talking about estradiol and testosterone. They can happen. They actually occur in different proportions of both men and women. So, certain amount of estradiol, it seems, is necessary even in men just to mediate some of the good effects of testosterone, like cardiovascular, bones, etc., and in the brain. So, estradiol to mitigate ADT side effects is now is actually not as widely practiced. I wish they would practice that one more. My first option would be no ADT. Then second option would be if you do ADT, then at least add some estradiol to it with high dose vitamin D, of course, to protect against ADT side effects. And the third option is something called bipolar ADT. And this is interesting because you can give androgen deprivation therapy for 2 weeks, 2 weeks on, and then 2 weeks off, then flood it with testosterone. So you actually alternate between high and low testosterone, bipolar, sort of confusing the cancer cells. Okay. And the last and most controversial one is actually to give mega doses of testosterone. And sometimes what happens when you give mega doses of testosterone, some of that gets converted into estradiol. So more testosterone, more estradiol. And the estradiol lowers PSA like a rock. You just drop like that, the PSA will. And you can maintain remission for a long time. This mega dose testosterone therapy is controversial because it's not approved, number one. But if you write or if you go to Harvard website and look up Abraham Morgan Taylor, so Harvard department, head of the Department of Urology is one Mr. Abraham, Dr. Abraham Morgan Taylor, Morganthaler, Morgan Taylor. Do look him up, and you can write to them or correspond with him. He's quite good about returning, correspondences. They've started a trial in Harvard using mega doses of testosterone in very, very early stage prostate cancers. Detected just incidentally, very small cancers. And the findings, of course, is not out yet, but it is showing a lot of promise that they're able to actually shrink the cancer cells. Now, how the pendulum swings, you know, on the one hand, was considered very toxic, and they wanted to get rid of it, and now they want to give mega doses of it. What gives? How did this happen? Because of the biphasic nature of hormones. Certain times, small doses of hormones cause what? Cause the effect, right? Of small to moderate doses. But in mega doses, huge, large doses, what does it do? It actually has the opposite effect. So this is quite a contradiction in endocrinology that doses, whether it's a small dose or a mega dose, can determine the action of the hormone. So it's not the hormone itself, it's how you use it. So just generally now, what about testosterone after prostate cancer? Can we, let's say somebody's 5 years in remission, that all treatment has been stopped. What do you do after that? Well, you can give testosterone replacement. In fact, it's recommended and is generally deemed to be safe. The very hormone that you're afraid of is now safe after prostate cancer is in remission. How did that happen? Again, same explanation. Testosterone had actually nothing to do with the prostate cancer to begin with. Um, just because getting rid of it lowered the PSA doesn't mean that it was causing it. So it's generally deemed to be very safe. And I'm going to give you a reference. This is one article that every urologist or every person interested in field of prostate cancer must read. In fact, if they were to read one article, it would be this: Mayo Clinic Proceedings of 2017. They had a whole section. In fact, the whole volume was dedicated to the World Congress in Prostate Cancer. They met, I think there were like 50 urologists from 11 different countries. They met and they talked about, the role of, they talked about testosterone in general and its role. Part of it was the role of prostate cancer. And they all unanimously agreed, all 11 countries unanimously agreed that testosterone did not cause prostate cancer, and that is actually extremely safe and actually highly recommended to give testosterone after prostate cancer, because God knows they've been deprived of androgen by ADT and what else. So it would be very highly recommended to give it after prostate cancer, and that giving it causes no harm. In fact, the rate of recurrence not only did not go up, but actually decreased. Okay, after giving testosterone after prostate cancer. So all the show of hands that said prostate cancer was dangerous, was bad, now might have a change of heart. Now, final conclusion: testosterone does not cause prostate cancer. I see no reason to reduce testosterone or cause medical or otherwise castration in a patient with prostate cancer when so many different options are available, much safer, and also based solidly on medical evidence, okay, and also on experience. So not only is this evidence-based medicine, it is also my experience-based medicine. That now in my practice, I should be doing some research, but haven't had a student thing for a while, in my office for a while, because I'd like them to collect all the data on the number of people that we're treating after prostate cancer with testosterone. Now, initially, when I started this, they were not very um, enthused about it, my urology colleagues. And now they've actually started referring me patients for testosterone therapy specifically after prostate cancer. Urologists are completely on board. The people who are not on board are the oncologists and the general practitioners. They're terrified. The oncologists are absolutely horrified that I do this, but the urologists completely understand it. Okay, so and Dr. Abraham Morgan Taylor from Harvard is a urologist. He deals specifically with male health issues. So it takes a person outside the field of endocrinology to move endocrinology forward. It's not the first time. It is oftentimes people from other disciplines contribute greatly to that particular discipline, although that is not their primary focus. Uh, Not just in medicine, but other fields as well. For example, Einstein was a mathematician, but he won the Nobel Prize in physics. So one has nothing to do with the other. Because if you're outside looking in, you have a different perspective. Whereas if you're inside looking in, you have a totally different perspective. So just burn this in your head, in your minds, that testosterone does not cause prostate cancer. Let me talk a little bit about the role of estradiol. Remember, we talked about adding estradiol to ADT back where it was. I was referred a patient who was resistant, calcitrant. PSA wouldn't go down no matter what. ADT was done, PSA was still high. So this patient, I put him on estradiol. The PSA dropped like a rock to almost zero. Okay. Now there are several actions of testosterone mediated by I would say a lot of the actions of testosterone are mediated by its conversion to estradiol or E2. It severely mitigates the adverse effects of ADT. So if you must go the ADT route, please give estradiol. Surprisingly, males can tolerate big doses of estradiol. One of my colleagues, he had prostate cancer, and he's on 8 milligrams of estradiol, and he'll tell you how much gynecomastia he does not have. Okay, it doesn't cause the man boobs and none of those things. It's actually remarkably safe and well tolerated in male patients. Um, Estradiol also happens to be, just like testosterone, apoptotic to prostate cancer cells. So you take prostate cancer cells, put it in the estradiol, the cancer cells just dissolve, they disappear. It's very well tolerated, as I said, with males with PCA. This gentleman is on 8 milligrams, has no gynecomastia, no female voices. It doesn't become, high pitched voice. It doesn't turn into a female, okay, or a transgender. Therefore, I will conclude that androgen deprivation therapy, as it is practiced today without estradiol, has too many side effects leading to poor quality of life and not necessarily prolonging life, just making it more miserable. There are several options to mitigate the side effects or choose other modalities. Testosterone, again, I would emphasize, does not cause, if you take away one thing from this presentation, is that testosterone does not cause prostate cancer. So please don't deprive your hypogonadal males of testosterone for fear of cancer. It doesn't cause it. Testosterone replacement is extremely safe and highly recommended if the levels, based on obviously, they are probably going to be low after prostate cancer treatment. With these conclusions, I'm going to keep the floor open now for questions rather. So please go ahead and ask away.
Definitely, I would read out what one of the participants has written. It's a lecture with a paradigm shift on hormones. So, definitely a very insightful session. Thank you for that. And I'm just going to check into the Q&A box. So, there was a question that if one has removed prostate, what are the chances of having it again?
Ashok, you can stop sharing.
Okay, I'll stop sharing. What are the chances of having what again?
Let me repeat
Uh,
the question for you. If one has
okay.
removed prostate, what are the chances of having, I believe, cancer again?
Okay. What are the cancer? Uh, Now you got me here because I don't have the exact numbers. But the recurrence rate of cancer, if it occurs, it happens early on. Unlike breast cancer, it doesn't take years and years to do that. Okay, right? So it happens early on. Uh, I'm trying to
Ashok, can I
yeah,
redefine this question? Sorry to butt in.
yeah.
Most people
Mhm.
have the prostate removed for
I
benign.
would like to keep you on spotlight. Just give me a
All
minute.
right.
The people
Yeah.
know that's Dr. Vivek Kadambi
Oh, okay. You're
speaking.
talking about
Okay. Benign.
benign.
Yes.
Okay,
And
then
then,
yeah, it can happen. It can happen. Sure. Hmm.
so,
It could.
yeah, if they were to,
There's no increased rate. I mean, there's
yeah.
no chance of it
I
getting
think
worse.
it's important to realize, Ashok, as we say that for benign, there are lateral lobes and the cancer occurs in the median lobe. So
Yeah,
when
correct.
if you had your cancer, your prostate removed for a benign hypertrophy, the risk of the cancer or the region
Can
where the
happen.
cancer occurs is still there. It can happen. There's no change. So
Yeah, yeah.
don't think that I've got my prostate operated for benign and therefore
Yeah,
I won't. It's
it
not
doesn't
like
give
breast.
you, yeah, it doesn't give you immunity.
All right.
It's not like
So,
a radical.
all right. Thank you very much. So, Dr. Sandeep had two questions. Is 17 alpha estradiol available for use in males? And does testosterone increase atherosclerosis and plaques?
Testosterone actually reduces it, and 17 beta estradiol is definitely available. Check with my brother, my mentee in Belsante. They can make it available.
All right. And how much of E2 would you recommend with ADT? Would it be transdermal?
Yeah, actually, I would just go oral. Uh, One or even try if they're afraid of blood clots, history of blood clots, they're obese, then you can give them transdermal, 2 milligram per ml up to 8 milligrams per ml, or the same dose orally. I'll start with 1 or 2 milligrams and keep escalating and watch the PSA. PSA will keep going down.
Sorry to butt in again here. Ashok, Indian patients don't tolerate the levels that your patients tolerate. So
Yeah. So you do smaller doses.
1 to 2 should be more.
Yeah. As long as the PSA has been watched, it should be fine.
All right. And there was a question, can testosterone help with building healthy immune system? Does help with cancer prevention?
Yes. In fact, both. Yes and yes.
Okay. And I'll just take one more question. So, any supplements that can help boost testosterone levels?
Unfortunately, I'm not aware of great supplements that do that. In fact, you can buy in America, there's a lot of people advertise like testofen and all that, but they're just short-lived. And longer term, the testosterone level comes back to where it was. So you may get a small boost, but it's not sustainable.
All right. And one technical question, what's the explanation for E2 reducing PSA in a refractory ADT patient?
Yes, because the estradiol is apoptotic, directly apoptotic to prostate cancer. So that's how it reduces it.
All right, perfect. So there were a couple of questions also in the chat. In the interest of time, I shall be going ahead with the next session. Thank you so much, Dr. Kadambi, for that very, very insightful, and that was a perfect start for the day, I believe. And if it was, dear participants, I would love to see a thumbs up or a clap or whatever you want to send across. Thank you once again for your wonderful time, Dr. Kadambi.